Good afternoon, good evening, everyone, to this presentation on efficacy endpoints in oncology. I guess the starting point for all of these things by now is our ICH harmonized guideline. If you look at that, you will find quite a prominent space dedicated to discussion of the primary endpoint, generally an efficacy variable, and there are recommendations to choose it among those variables that are capable of providing the most clinically relevant and convincing evidence directly related to the primary objective of the trial. It's an important definition. Now, since a few years, we have an extension of this guideline, particularly when it comes to endpoint, introducing the concept of estimand. We've seen this some of the sessions before. Basically, it's about the idea that it's kind of difficult to discuss endpoints in theoretical terms, things like progression-free survival, quality of life, unless we clearly defined what we mean by them. And it turns out that in order to clearly define something, um, we need to express how we measure it. And measuring something in a clinical trial isn't just about the tool or the caliper that is being used to take a measure, but it's broader. It has to do with the population. It has to do with handling intercurrent events and anything else that occurs. So the focus of this additional um, uh, addendum to the ICH9 is really to explain about that. I must say that compared to other therapeutic areas in oncology, there was quite a lot of thinking about estimands already. We would always carefully think about the population, should it be an intent to treat or not, modified or not, why, etc. All of this is part of the endpoint definitions now in what we call the estimand. Now, you can soon realize that with so many different aspects involved, choosing the right endpoint is not trivial. And there's a nice classification in this textbook which talks about criteria such as relevance, being able to quantify, validity about measuring the intended effect, an effect that should be the same, interpreted in the same way by all observers, reliable, sensitive, specific, precise, etc. And there are also other considerations which are less of a, let's say, methodological nature, which are like tradition. We are often inclined to repeat things for many reasons, but in clinical research, obviously, it's also advantageous because then you can compare indirectly, and there are other considerations like cost, time, missing data. So far from trivial a topic, it's actually one of the most controversial topic and most interesting I find in drug regulation, because it goes down really to the essence of what we want to do, what this is all about. If we take a historical perspective, in the 70s and 80s, apparently the WHO criteria and tumor response rate alone was used. We are talking at a time where the development was mainly non-commercial, and really there were no drugs available. So these are the borderline between experimental and confirmatory trial was kind of blurred. And it was in the 80s, mid 80s, that what I would call a phenomenological bias was introduced, basically meaning that the endpoint shouldn't just be a measure of something, but it should be something that has a subjective meaning, something that is perceived by the patients. So some type of improvement or a symptom that improves, something tangible that is perceived from a sort of subjective perspective. And this is an important introduction because all very often discussion on endpoints, validity of endpoints, on clinical relevance, and so on, rely on this specific point. And one of the things you need to ask yourself, is this phenomenological bias the only thing that matter? And I'm going to leave the question perhaps open to you to ponder about. Anyway, in the 90s, many more endpoints were introduced, like variations of the ones that we had, like disease-free survival, event-free survival, and so on. And also other type of endpoints like a bridge to transplant or avoiding surgery, invasive surgery, durable responses, etc. Now, the go-to documents are listed at the bottom of the slide. One is our anti-cancer guideline, and the other one is the FDA endpoint guideline in oncology. They're very similar, different in the level of detail and so on. There are some differences that I will highlight in a minute. But if you want, in this talk, I will not go into every detail of what this guideline lists, just present a few concepts, and always remember that these are the two documents that you want to go back to really get a comprehensive view on the topic. If we look over EMA's lifetime, let's say at least the first couple of decades, we see that there has been varying trends. Perhaps the most notable that some people deplore, others find progressive, is the rise of PFS as primary endpoint. And we're going to see later uh, how that came about. But why is it deplored? Because many argue overall survival is a hard endpoint, not subject to investigator bias, is the gold standard. And this has been repeated over decades by, I would say, a majority of regulator, clinicians, patients, and so on. Now, despite the fact that everybody agrees that ideally overall survival is uh, highly desirable, there are issues. And some of the issues that are less well known are competing risks, so deaths due to other causes, the effect of further line of treatments, which can make it much more difficult to detect survival, the effect of crossover in certain designs, the the fact that it takes a long duration of follow-up and large sample sizes to detect small effects. And lastly, that it does not take quality of life into account. So think of prolonging survival in for patients who are uh, under uncontrollable pain or perhaps not conscious. I guess there will be different views on whether that is a clinically important endpoint. And another misconception is that if you have an improvement in survival, that necessarily means an approval. No, it doesn't. There are examples where this was not the case. Why? Well, it is always a matter of benefit risk. And I think one take home message from today is that this focus on the primary efficacy endpoints, the endpoint among all endpoints, the primary, the key estimate of all estimates, is actually not the whole story. Drugs are not approved on a single p-value of that endpoint. They are approved on the whole, on the totality of data, and particularly on the benefit risk assessment. So it's always seen in context, and if the benefits do not outweigh the risks, then the marketing authorization application is refused. Moving on to the other endpoint, perhaps the most controversial among the efficacy endpoints, we have progression-free survival. There is a conventional definition which distinguishes it from, for example, time to progression based on how death is censored. And this is really a, um, a very particular case of composite endpoints, which um, we don't talk a lot about, but actually raises some important issues. In this endpoint, you have things like a small increase of a tumor on a CT scan. That could be an event that triggers a progression, but also you could have death. And now, in a benefit risk assessment where you have to assign value judgments, you can well understand that it's difficult to assign value judgments to such an aggregate of different events with different meanings. And we'll come back to this and possible approaches to change this. But if you want to look at a regulatory controversy, this is one where people have really written about how regulators get it wrong, and that all those justifications for using progression-free survival are actually not that great. And I invite you to read some of the literature here. Now, um, I not discuss it here, but in detail. But this is also progression-free survival is also one of those endpoints where the two guidelines, EMA and FDA, diverge. So it would be interesting, perhaps, if you want to dig deeper, to look at where they diverge. And really, it is in the definition of the estimand. So how to handle the intercurrent event. I could try to simplify it for you, and in a nutshell, I would say that EMA's approach favors generalizability. In other words, we say, well, the progressions should be adjudicated whenever there is documented progression, regardless of what happened before, violation, switch of treatment, missed scans, whatever. In the end, it is what will have a clinical impact. So when the progression is actually documented, of course, trying to avoid all sorts of violations if possible. But once they do occur, the best way is just to look what happens in real life, in clinical practice. The FDA took a different approach. They were more concerned about, well, if there is a switch of treatment and you're measuring PFS, but actually it's not due to the drug, but you've switched to another drug, maybe the effect could then be due to this other drug. So you need to be more focused and try to single out the effect that can really be causally related to the drug, measured precisely, missing scan, have an impact on how this can be handled. And so you see, diverging the definition of estimates, which are very interesting, and really there's no right or wrong way of doing it. It's just a matter of perspective. Just to show you how varied the views are on this endpoint, I can show you the results of a survey that we conducted recently, and we asked regulators, the histograms in blue, and healthcare professionals, oncologists and hematologists, to tell us how much toxicity they would be willing to trade off for a 6 month increase in PFS. And at the left side of this chart, you see those who would trade only very little toxicity, and there was a sizable amount. Actually, the most frequent category among clinicians was to trade off very little uh, for a 6 months PFS gain. And at the other extreme, you would have regulators on this side who would trade off as much as a 60% incidence of grade 3/4 toxicity for that same amount. And we can later discuss, if there is time and interest, why this could be. But I think what's interesting in this slide is this distribution, almost a bimodal distribution, almost two distinct groups of believers in PFS and non-believers in PFS. And I guess that's something that as a regulator, you always need to take into account, because in the end, you need to decide where you stand, not only with your own beliefs, but also should you, rather than apply your own belief, accept the beliefs of patients, doctors, and then decide accordingly. And this is an important consideration for regulators. Of course, often we want to know precisely what is the patient perspective. And if we ask the same thing to patients, how would they weigh things like progression-free survival, uh, grade 3-4 toxicity, or chronic, let's say, moderate toxicity. Again, I'm not going to explain in detail this slide, but every dot here shows where one patient would put all the weight. And the three vertices represent each of these three variables, one of them being PFS. And you see that there is quite a cloud of distribution again, different opinions, different views about the importance of PFS, from some who consider it extremely important, others who consider it of very little importance. And we've tried to figure out what are the core beliefs that determine these different views. And I think one is, for those who believe in PFS, there are at least two important elements. One is the idea that of surrogacy, that although this has never, or very, very rarely, empirically demonstrated, and you know how difficult the whole topic of surrogacy is to demonstrate anything conclusively, but so without evidence, there is still a belief that a sizable impact on progression-free survival must mean something good in terms of quality of life and duration of survival. That's one element. The other element is that some believe that actually there is an intrinsic benefit per se. So if in certain situation, often we're talking about, let's say, more extreme, more advanced situations, knowledge that the tumor is not growing in size or number of lesions from a response is considered a benefit. And this intrinsic benefit has again to do with a slightly more open mind than the pure phenomenological, let's say, interpretation of endpoints, even if this is only on a scan. But it makes a lot of medical, biological sense that going from no lesions to multiple lesions, or one lesions, or a bigger lesions, that it's not a great thing. And so this takes this more, how should I say it, open approach to interpreting the relevance of endpoints. And ultimately, it's a matter of value. So yes, it might have a value. It might be an endpoint that people consider to some clinical relevance, but how much relevant this is, well, that is a matter of subjective judgment. And again, one needs to position themselves. Are we the ones who should impose our own value judgments on others, or will we allow that patients and doctors in the right decision context are, perfectly not just capable, but that we should respect their value judgments? There are no fixed rules, and this is where one needs to position themselves. Now, despite the believers of PFS, there is also huge agreement. Sorry, believers and less believers than PFS. There is also huge agreement on the catalog of problems with PFS, including things like informative censoring and all the problems that can arise from various type of missing data and unscheduled evaluation, to the worst possible problem that is really systematic error introduced through measurement bias. Say one believes that the experimental treatment is more effective, so doesn't conduct the examinations with the same frequency. And actually, there was a famous example quite a few years ago that was illustrated at an FDA oncology drug advisory committee. And this is a slide taken from the FDA presentation, where it was showing that the time to the scan was shorter for the control arm. And obviously, if you measure more aggressively, you will detect progressions early, just because you're measuring more on one treatment arm. And yeah, so the problems with PFS are well known. I think I've discussed before the guidelines in our previous talk. We have a whole guideline on methodological consideration on PFS, which again, if you're interested in digging a bit deeper, you will find quite comprehensive there. Now, often when the problem is reduced to which endpoints, and I've told you already, this isn't the right question. Is it OS or PFS? It should be much more how to assess the benefit risk in different situations. But if you want me to try to summarize it really in this oversimplified way, I would say that the prevailing views is that overall survival remains the most convincing endpoint for confirmatory trials. It's valid and reliable, at least for most people. PF, progression-free survival, is acceptable, but it's not straightforward. It has to be argued why, in certain situations, perhaps being the duration of the PFS effect, this can be perceived, interpreted as something having some type of effect on quality of life, overall survival, or why it is to be considered an intrinsic benefit per se. And this is very controversial when the effects are small. Now, there is a bit of a myth, although you can see where it comes from. It's again about benefit risk. It's the idea that PFS effects can only be looked at positively if there is not detriment in overall survival. Again, it's not quite as black or white as that. It's more that it's a benefit risk issue. And obviously, if one has a small PFS effect and a huge detriment in overall survival, nobody out there will want to have such a drug. There has to be, if at all, uncertainty about overall survival. It has to be very well in proportion of the gain that is anticipated through the PFS. Again, uh, an invitation not to look at these endpoints in isolation, but to always look um, at the benefit harm balance. Now, PFS is also often discussed in the context of treatment switches. So these are these designs where patients are randomized to often a new experimental arm and say a placebo or a very obsolete or mediocre control arm, and then following progression of disease, there can be switch from the control arm to the experimental arm. This is problematic because one then kind of destroys the ability to detect the pure effect of the drug on overall survival, which is often then the secondary endpoint. And then there are all sorts of discussion about statistical methods that can a little bit explore what's the impact of the switch, but they're not perfect methods. Or on the other hand, then people say, well, why do you do it? Don't do it. And then people say, oh no, but we have to do it. Otherwise, patients would not accept to be randomized in those trials. And then we say, but hang on a minute, well, if they wouldn't accept then isn't there maybe a question of equipoise from the start, and how is the prospect of a switch after a progression the same of as treatment with the experimental arm up front? So basically, other difficult problems that come with progression-free survival. Now, turning the page to another endpoint that features more and more prominently in our discussions is health-related quality of life. I say discussions rather than approvals because if you look at our approvals, and I've shown the graph in the beginning, quality of life endpoints are still the absolute minority when it comes to the primary efficacy endpoint. But most developments with randomized trial do include this type of studies. And even if they don't occupy a prominent role in the efficacy section, they're always looked at as an additional piece of information. So they're more of corroborating endpoints, call them secondary or exploratory. But people start looking at them more and more, especially in the context of progression-free survival, when one needs to put a bit more into context the toxicity and the gains for the patients. And a question we often get is, hey, we submitted the quality of life study. It took tremendous effort from patients, doctors, nurses to collect, and you regulators are ignoring it. You're just talking about the PFS and the grade 3/4 toxicity. I would say, whereas we want these effects to be in the summary of product characteristics and sort of be able to claim an effect on quality of life. And there often the problem is not the endpoint per se, not at all, but it's just whenever we have secondary endpoints, it's very difficult to attribute the weight of evidence, how reliable these results are. Often they're not pre-specified analysis, and there are problems of missing data, etc. And so the reason for not seeing it so much in the labeling is just one of hierarchy in the evidence, and it's not at all one of being dismissed or anything. We actually, Caroline, who is hosting this session today, organized together with the RTC recently a workshop on precisely this topic and seeing whether there is anything to be done in terms of facilitating or improving the use of these endpoints in the regulatory decisions. Now, lastly, moving to the endpoint of objective response rate, I guess it's in the end of the presentation, not so much because we don't encounter it, but because we look at it not as an efficacy endpoint per se, but more as we call it an endpoint that measures activity, a terminology that is often used in exploratory phase 2 studies, something that shows that something is promising or very promising in the context of a conditional approval, but not an efficacy endpoint per se, with exceptions. So, for example, when there is tumor shrinkage is associated with a clear decrease in symptoms, but then of course it's a symptoms improvement and it's not really the point is not really the response rate, or in situation where there is a huge let's say effect, ideally also accompanied by duration of response. Now what's really important about this endpoint and why it's used a lot in single arm trials is because the causality of the association between the drug and the endpoint is often quite acceptable. Tumors don't shrink on their own. So if you see a 20% response rate, you can say most of it is likely to be due to the drug. Now, the same you cannot do, you cannot say for any of the other endpoints that we've seen before, like progression-free survival, overall survival. They're affected by so many other things than the drug that really, when you see something, unless it's extreme, it's very difficult to do anything with that. And then, okay, there are ways to deal with that as well, either extreme effects or indirect comparisons or more sophisticated comparisons with the external controls. But in general, these time-related endpoints are difficult to look at, contrary to response rate. Interestingly, and often less noted, is the fact that duration of response, which is always taken, let's say, combined with response rate to assess whether that response is meaningful or not, is as affected by these other factors, these non-causally related factors, as progression-free survival and overall survival. So despite the fact that we will always look at the two together, really duration of response is a bit more difficult to interpret. And here I'm going to have an example where actually response rate was sufficient as an efficacy endpoint. So this is one of those exceptions where this activity endpoints actually, from a regulatory point of view, is enough to decide this drug works. And for that, you need many things, including understanding the biology, an effect that is crystal clear, no fantastic other alternatives, etc., etc. And so these exceptions do exist, but they're very rare. Otherwise, Response rate is an endpoint that can be used for conditional marketing authorization, but then requires, as soon as possible, a confirmation. So I hope that in the end, you've seen that more than endpoints, more useful discussion is a discussion on benefit risk assessment. Because even if we choose the perfect single endpoint, well, efficacy, yes, efficacy is a criterion for marketing authorization, no doubt. That criterion will be fulfilled with a single, let's say, treatment comparison. But there is another criterion, equally, if not more important, that is the benefit risk balance must be positive. So how do you, as regulator, put this together? On one side, we have fully inferential, multiplicity adjusted, single primary endpoint, yet your decision is made on benefit risks. So this is a much more, how shall I say it, complex, comprehensive, holistic decisions that needs to take into account not just the primary efficacy endpoint, the safety endpoints, the secondary endpoints, and all these other aspects that go into the evaluation. So the choice of endpoints in isolation really doesn't make a lot of sense. One should always look at it in terms of how is the benefit risk assessment going to be performed. And actually, here, um, are we not sometimes missing the point of what we're doing with this overemphasizing the single primary efficacy endpoints? Could we think of better ways of doing it? And I'm just going to illustrate two because they're close to my heart for different reasons. But this copy paste approach of protocol and statistical section just to create sort of fit for regulatory purpose trials is something that locks us into traditions but doesn't allow us to innovate a little bit. And like the idea of being more inclusive of endpoints like quality of life, patient preferences that deal with slightly different aspects that have been perhaps more neglected in the past. So why don't we think perhaps of additional ways that there are to look at these efficacy endpoints? So I invite you to follow the new proposals and new trends. Uh, Here, this would be the traditional way of looking at benefit risk. You would have the primary endpoint, look at the Kaplan-Meier curve, calculate medians, or calculate the proportion of patients, whatever, alive and without a progression at 12 months, for instance, calculate the cumulative toxicity in this whole population, come up with what we call an effect stable, and then you need to balance, is this effect on PFS, is it good enough to outweigh this negative effect on toxicity? And it's kind of difficult to balance these different things, and then progression-free survival include things like death, and so which one is a benefit or a harm? It becomes difficult to sort of compare these almost abstract quantities. And this is how we do the majority of benefit risk assessments today. It kind of works at the population level, but if one were to think of correlations between these things at the patient level, so what if the patients who get the toxicity are the ones who get the benefit and vice versa? So um, it's a bit crude the way we do this thing. So an approach that we have been experimenting with is uh, um, an application of multi-state modeling, basically looking, instead of looking at an effect on the endpoint, let's look at where patients spend their time during their treatment. And by where, I mean time spent maybe progression free and without toxicity. That should be a very important part. Time spent progression free, but with a lot of toxicity. That that is more tricky because the value judgments about the time are gonna vary quite significant, etc. So here in these two graphs of kind of predicted survival, you see two drugs with rather similar overall survival. Perhaps the the control arm has a slightly poorer overall survival, a bigger red area, if you want. But um, how to get there is very different. So in the experimental treatment, you get much more time spent in the yellow area, which is the one where patients are experiencing toxicity. So taking this patient-centric approach really changes completely the estimate. And I wonder, i- could this not be, let's say, a useful way to supplement, of course, the traditional way we do things with, a different type of benefit risk analysis? And here you would have to balance these type of quantities, and of course, it's also difficult to balance them, but at least they're kind of on the same scale of the from the patient experience point of view. Another radically different approach and much much better established also in the literature is an approach called generalized pairwise comparison. This tries to tackle the problem that I was describing before with progression-free survival, where you lump together events which are quite different, like tumor growth and death. And it recommends sort of a priori to set a hierarchy of importance of these events. Again, you see, including importance in the way we analyze these effects, it kind of give a patient centricity that wasn't there before to, in this case, in this proposal, the primary analysis, and then hierarchically analyzes the component, uh, for example, in the order of importance. For example, death might be considered much more important as an event as a tumor growth, and there can be all sorts of intervals to decide this type of pairwise comparison. So I told you I chose this is a biased choice of, let's say, innovative ways of thinking about the benefit risk assessment and the primary endpoints. But please keep an open mind, because I think we are entrenched in our traditional ways of doing things, but probably things will continue to evolve. We've seen it with quality of life. We are seeing it with patient preferences. Now there is ICH work on developing guidelines how to measure patient preferences in the context of, let's say, industry and regulatory authorities. So there is a lot happening in this space. And this leads me to my last slide with really three take-home messages. One is not to over focus on the primary efficacy endpoints. Often that's the only thing people talk about, but no, a benefit risk assessment is done on the basis of a whole dossier. And it's a case of not seeing the forest for the trees, really, when one singularly focuses on the p-value for one treatment comparison. The more useful concept is the balance of benefits and harms, the totality of the data, including strength of evidence and corroboration through a multitude of endpoints and better estimates. Because really, the other thing we need to think about is discussing theoretically about PFS. Is it good or is it bad? Yeah, it's almost meaningless unless we put it in the context of how we measure it, in what population, how do we deal with intercurrent events, missing data, etc., etc. The shift to the estimate framework is really, from an epistemological point of view alone, a necessary one. And lastly, let's keep an open mind. These are evolving fields where we need to be efficient in making really the most useful information that we can get out of this development, and looking at a multitude of endpoints and perhaps in a different ways can really enrich our experience from drug development. And with this, I close. I hope this was interesting